Hello and good evening, my colleagues from all over the region. The International League Against Epilepsy Eastern Mediterranean region welcomes you to our regular webinars. This session of webinars has two sessions for your benefit and our benefit too. I'm going to introduce our first speaker, Dr. Taoufik Alsaadi. Dr. Taoufik is the Chief Medical Officer and the Chair of Neurology Department at the American Center of Psychiatry and Neurology. He was trained in epilepsy and clinical neurophysiology at the University of California, San Francisco, and was a research fellow in epilepsy there. He is board certified by the American Board of Psychiatry and Neurology and by the American Board of Clinical Neurophysiology and by the American Board of Neurology in Clinical Epilepsy. Before joining ACPN, Dr. Alsaadi was the chief of the neurology department at Sheikh Khalifa Medical City for 11 years. He previously held the position as an associate professor of neurology and the director of adult epilepsy program and clinical research program at the University of California, Davis. His research has focused on conducting drug study trials for new anti-epileptic drugs for patients with epilepsy, quality of life in patients with epilepsy and non-epileptic disorders, migraine headaches, multiple sclerosis, and neuropsychiatric comorbidities. Dr. Alsaadi has been honored with several prestigious awards for his work in the field of epilepsy. He has served on the advisory board of the Northern California Epilepsy Foundation and on the membership committee of the American Epilepsy Society. He has previously served as the president of the Western Clinical Neurophysiology Society in the United States and as the vice president of the Commission of the Eastern Mediterranean Affairs Committee of the International League Against Epilepsy. He is currently the president of the Emirati League Against Epilepsy. He also serves at the editorial board for BMC Journal of Neurology and Journal of Neurosciences. He has authored and co-authored more than 60 papers and book chapters and has served as peer reviewer for more than 15 scientific journals. Dr. Taoufik, we welcome you and you may start your presentation.
Good evening. First of all, I would like to thank the organizers, Dr. Fatima and Dr. Abdulaziz, for their kind invitation to ask me to come and speak to you in this webinar. So I've been given the task to speak on the role of traditional and not traditional options to manage patients with epilepsy. So what I thought I could do in the coming 30 minutes or so to speak on the role of neurostimulation in managing patients with epilepsy. This is my disclosure. And the objectives of my talk, I will try to review with you the role of neurostimulation therapies in the management of patients with refractory epilepsy. We'll highlight the mechanism of action and adverse effects of this model of treatment, and we'll review some of the indications for various epilepsy syndromes. Let me start off with some epidemiological data. We know that at least 2.5 million people in the United States would have epilepsy, and about 65 million people worldwide would have epilepsy. At least 1 in 26 people in the States would develop epilepsy at some point in their life. And we know also that epilepsy is the fourth most common neurological disorders in the States after migraine, stroke, and Alzheimer's disease. And there is at least double the number of patients with, as compared to patients with ADHD, multiple sclerosis, and Parkinson's disease combined. Certainly, the disease has an economical and cost. Most of the cost come from indirect costs because of loss of productivity, but there's also some direct costs related to the obviously caring for these patients in terms of hospitalizations, visits, medications, etc. But most of the costs, as a matter of fact, comes from indirect costs. This disorder would affect patients at multiple levels and multiple domains, but one area that is often being overlooked, that these patients are discriminated at in their work setting. And indeed, 25% of patients with epilepsy are not able to attain full employment due to their epilepsy. And of these, 2/3 would state that they are unemployed as a direct cause of their epilepsy syndrome. Regardless of what treatment we choose, the goal of treatment is no seizures, no systemic and cognitive side effects, avoidance of long-term impact of that treatment on metabolic profile, bone health, endocrine function, and very importantly on mood. And the ultimate goal of whatever treatment is to improve the quality of life in patients with epilepsy. We ended up with so many options, so many drugs that we can consider from in managing patients with epilepsy. But still, as you can see from based on the Rappaport data, I know this is an old data, but pretty much I'm sure if we replicate that data nowadays, we're probably going to come up to a closer figures that we have seen back then, where clearly have shown that 2/3 of patients would have recurrent seizures, 2/3 would have side effects, and 40% or so would have both. And only 15% of patients with epilepsy would have the ultimate goal, meaning no seizures and no side effects. Now, for patients with epilepsy, what it matters is no seizures and no seizures, period. This is the data from Barbara Vickery in patients who underwent temporal lobectomy. Clearly that it shows us that patients who had seizure-free, who have become seizure-free, including aura-free, would have a better quality of life as compared to patients who had auras only, or as compared to patients with other chronic disease states, including those with hypertension and heart disease. So the goal is no seizures and no auras, period. But we have learned over the years, especially with the introduction with the second and third generation anti-epileptic drugs, we have learned of the role of 5, meaning you probably have to treat 5 patients before you can get one of them to become responder with less than 50% reduction of their seizures. We have also learned the role of 17, meaning that you probably have to treat 17 patients before you can get one of them to become completely controlled on whatever drug you choose, first, second, or even future generation of anti-epileptic medications. Obviously, the ILAE task force had come up with a new definition of drug-resistant epilepsy, which is defined as a failure of adequate trial of 2 tolerated and appropriately chosen AEDs, whether as monotherapy or as in terms of combination, to achieve sustained seizure freedom. Now we have data suggesting that to us that patients with epilepsy can be subdivided right from the outset. For those who are easy to control or respond to treatment, if you choose obviously the right medication, and those represent about 60 to 70% with patients with epilepsy, and the subgroup of patients who are difficult to control right from the outset, representing about 30 to 40% of patients with epilepsy. Obviously, in the United States, at least 400,000 people in the state would have refractory partial epilepsy, and each year we have 5,000 people would become refractory. Well, we have to look at the group of patients with refractory epilepsy at multiple dimensions. Those patients have multiple seizures, uncontrolled seizures. Obviously, they're taking multiple drugs, so there's excessive drug burden, cognitive problems as a result of the excessive drug burden, as well as of the duration of seizures or their underlying epilepsy syndrome, psychosocial dysfunction, restricted lifestyle, and ultimately, and as expected, unsatisfactory quality of life. And that's obviously would call for early intervention in patients with refractory epilepsy because of the cognitive and memory issues that we had explained earlier, the neurotoxic adverse effects of the various AEDs. In addition, we have some data suggesting to us higher SUDEP rate, in patients with refractory epilepsy as compared to patients with easy-to-control epilepsy, higher injuries, higher depression scores in patients with refractory epilepsy as compared to easy-to-control epilepsy, reduced lifetime income, and increased healthcare utilization in the group of patients with difficult-to-control epilepsy. We have various options to manage these patients. Ketogenic diet can be an option for a selected group of patients, but if your patient is surgical candidate, certainly that will be the best way to go. If you look at the data by Sam Weeb, clearly have shown that patients who are randomized to the surgical group as compared to the patients who are randomized to the medical group would have a better outcome as compared to patients who are randomized to the best medical group. Not only that, patients who are randomized to surgical group would have a better quality of life as compared to patients who are randomized to the best medical arm. Now, what about patients who are not surgical candidates? What sort of options we may have for these patients? Obviously, for that population, neurostimulation can be an option. And estimated based on the data by, in the United States at least 700,000 patients could be candidate for neurostimulation devices, but they're not offered that mode of treatment. Based on FDA approval, VNS obviously was the first approved modality. Then we have the cardio-responsive version of the device. RNS is approved back in 2013 based on specific indication for those who are above the age of 18, partial onset, frequent and disabling seizures, diagnostic testing localized to less than 2 epileptogenic foci, refractory to at least 2 AEDs. And as you know, deep brain stimulation is not approved by the FDA, but it's approved by the EMEA for that indication. The VNS was the early device that had been approved by the VNS by the FDA for the indication for patients with partial onset seizures. As you know, based on a simple concept of mild electrical pulses applied to the left vagal nerve and the next sending signals to the brain, with the concept of automatic intermittent stimulation. Obviously, having the magnet in place would allow the patient or the caregiver for on-demand stimulation or to adjust the side effects they may perceive with this device. In addition to that, has the advantage of better compliance, which, as you know, is a big issue in patients with epilepsy. The early work goes back to the New Yorker neurologist Kerning back in the 80s. And he basically developed the first instruments for carotid artery compression for treating patients with seizures using the carotid fork for acute abortion of seizures and the carotid truss for prophylactic treatment. And based on his uncontrolled observation, with the abortive treatment, there was decreased duration of seizures, and with prophylactic treatment, there was decreased frequency of seizures. And later he added the transcutaneous electrical VNS for patient with epilepsy. This is the carotid fork, and this is the carotid truss, and this is the electrocompressor. And here you can see a sketch showing the early VNS using the external stimulation of the VNS, which pretty much simulate what we do nowadays. How does it work? We seriously don't know, but we have some work based on PET, SPECT, as well as fMRI, as well as EEG data, suggesting there are some changes at multiple areas of the brain, cortically and subcortically, with some correlation of the activation of various areas in the brain with the level of seizure control. This is the work on EEG, based obviously on a small number of cases, suggesting how the VNS may abort seizures. And this is the work by Q, when applying the VNS, have shown progressive changes in the form of clustering of epileptiform activity, followed by progressive increase in the periods of spike-free intervals in both children and adults following the VNS implantation. Eleanor Bermanakem have looked at the CSF chemistry before, 3 months, and 9 months after the implantation of VNS, looking at specific neurotransmitters, and her observation has suggested increased neuronal membrane synthesis after long-term seizure antagonism by the VNS therapy. This is our work with the fMRI showing multiple areas of activation, in addition suggesting the safety of VNS in patients who undergo MRI imaging. The first implant was back in 1988 by Kevin Pendry, and now in 2020 we have more than 100,000 patients had been implanted worldwide with VNS. The early approval of the device had come after two main pivotal trials, the EO3 and EO5. Both were randomized, blinded controlled trials that included patients with refractory epilepsy that had failed multiple AEDs with good number of seizures per month. As you can see, more than 6 per month. And patients were randomized to either high stimulation group as compared to low stimulation group, and included patients with 12 years of age and older, 6 seizures per month, who had failed more than 1 to 3 baseline anti-epileptic medication. If you look at adverse effects, voice alterations had been reported in about 2/3 of patients and cough in about 45% of patients. Now, where to place the VNS? Well, based on our understanding so far on how the drugs work and the responder rates after failure of first, second, or third AEDs, as you can see very clearly here, that once patient had failed the second drug, these patients should be considered for either epilepsy surgery or for VNS or other neurostimulation devices early on. If you look at the data that was published a few years ago, based on analysis of registry data comparing early group, meaning that those who are considered for VNS less than 5 years after epilepsy onset as compared to the late implanter, those who had early VNS implantation had a better responder rate in terms of 75% reduction of seizures, 90% reduction of seizures, or becoming seizure-free as compared to the late implanters. As you know, the FDA had granted the approval for the VNS for those with above the age of 12 in 1997, for those with history of partial onset seizures. Then we have the cardio-responsive version that was approved in 2015, and in 2017 we have the children approval for those above the age of 4. Despite the approval for patients with partial onset seizures, now we have data suggesting its efficacy in other epilepsy syndromes, including those with the Lennox-Gastaut type. This is the data by Mark Frost looking at the responder rate at 6 months, where 2/3 becoming responders, and about 40% had more than 75% reduction in seizures at 6 months mark. If you look at the drop attacks, again looking at 3 months or 6 months, and looking at the median reduction of seizures, 70% of patients have responded after the VNS implantation, and obviously had led to some debate in the literature in patients with atonic or tonic seizures if we should go for VNS versus the invasive procedure with corpus callosotomy, and the jury is still out about this debate. This is the data by the Yale group suggesting the efficacy of VNS in patients who had failed prior epilepsy surgery, including those who had failed previous corpus callosotomy. In addition to that, there's some data, this is the data by Oren Devinsky, for patients with difficult to control or refractory idiopathic generalized epilepsy, suggesting good responder rates in the group of patients with idiopathic generalized epilepsy. Similarly, the work by Kostov suggesting good responder rates for various seizure types, GTC, absence, and less so with myoclonic seizures in patients with refractory idiopathic generalized epilepsy. Now, what about patients with independent temporal lobe epilepsy? Similarly, we have seen some good results, this based on my group work on in CSF, UCSF, suggesting the efficacy of VNS in the group of patients with independent temporal lobe epilepsy. Obviously, these patients are not surgical candidates. Safety profile, we know there is no reported idiosyncratic reactions, and there is no increased SUDEP rate in patients with VNS. And very recently, we have seen the results by Ritalin based on 40,000 patients with VNS therapy. There were reported 3,600 patients with death, 531 with possible SUDEP, and 101 patient with probable or definite SUDEP. And the rates of SUDEP per 1,000 patients years in people with drug-resistant epilepsy as compared to historic control of 5.9 after implantation. If you look at the 1 to 3 years data, it was 2.47, and based on 3 to 10 years, it was 1.68. Most of the adverse effects that we see with VNS tend to be transient, and they tend to diminish with time, and they can be adjusted with some adjustment at the level of the neurostimulation parameters. As you can see in the slide, most of these side effects are transient, and they tend to improve over time or with some adjustments. What about long-term follow-up data? If you look at the retention rate, some data suggests retention rate as high as about 60%, including the first two trials on the left, LABAR, that included patients whom he stabilized them on the same AEDs throughout the VNS implantation. Still, we have seen significant reduction in seizures and maintenance of that reduction over several years of follow-up. Now, what about based on meta-analysis of all the studies that we have so far? This is the data by Engelot, looking at 74 clinical studies. 15 were prospective and 59 were retrospective studies. If you look at the pooled data, looking at the responder rates, 50% of patients were responders, where the odds ratio of achieving good response was about 1.83, with 4% of patients becoming completely seizure-free. Now, what about the subgroup of patients who are best candidate for VNS? Well, based on this meta-analysis, those who had follow-up more than 1 year, those with generalized epilepsy, younger age, post-traumatic epilepsy, or those with TSC diagnosis. However, there was recent data that came from Epilepsy, looking at several parameters that we can look at in order to tell if our patient would or would not respond to treatment based on systemic biomarkers, looking at the heart rate variability, network-based biomarkers, electrophysiological markers, as well as structural findings on neuroimaging that would help us decide if our patients would or would not respond to VNS therapy. Obviously, this slide to remind all of us that patients with epilepsy, they are not only suffering from seizures, they have other comorbid conditions that affect the overall quality of life, including mood issues, sleep disorders, as well as memory difficulties. And as you can see from this work here, that patients with epilepsy are at higher rates of having depression as compared to patients in the general population. Not only this, we have seen based on 5 studies here that depression is an independent predictor of quality of life in patients with epilepsy, whereas seizure frequency was not. So the higher the depression score, the worse quality of life would be in patients with epilepsy, whereas the seizure frequency was not. And that's obviously called to screen for depressions in patients with refractory or with epilepsy in general. The VNS had been approved by the FDA for patients with drug-resistant depression who had failed more than 4 antidepressants. That indication was granted back in 2005. And there was recent work based on meta-analysis of all the studies of depression and epilepsy has suggested that VNS is a valid option in patients who have epilepsy and comorbid depression. Now, there are some also data suggesting a positive effect of VNS in terms of alertness as well as improvement in mean sleep latency. What about the quality of life? We have a recent randomized open-label trial by Ritalin where patients with difficult to control epilepsy, included 96 adults, were randomized to either VNS plus best medical treatment as compared to patients randomized to best medical treatment arm, looking at primary outcome, which is the quality of life, and the secondary outcome measures, including the seizure frequency. All the primary and secondary outcomes came in favor of the VNS as well as the best medical treatment arm as compared to the patients who were randomized to the best medical treatment arm. In addition to that, the use of the magnet, at least based on 20 articles review by Bob Fisher, suggesting that 45% of patients would perceive some benefit by just the application of the magnet stimulator. In UK, there are some data suggesting that the use of VNS had been associated with a significant reduction in healthcare resources, which is a very important concept to keep in mind when managing patients with epilepsy. Obviously, that was the old model of VNS. Now we have a newer model of VNS based on the concept of ictal tachycardia that can be appreciated after either partial or generalized seizures. And as you can see from the slide, at least 60-70% of patients would have ictal tachycardia either in partial or generalized seizures. And that was the concept of the new device that would sense this change at the level of the heart rate. And the approval of this device had followed the two pivotal trials, the E36 and the E37. One of the trials was conducted in Europe, the other one was in the States. And they looked at patients with medically refractory epilepsy, who are obviously are candidates for venous surgery. And they looked at patients who had increased heart rate associated with seizure onset. And the objectives of the study was looking at the performance, safety, as well as the efficacy of this device. And the trial design looked at patients who come in for EMU monitoring for about 3 to 5 days with some adjustment to their setting, followed by the open label of the phase of the trial. And this is basically how the design of the trial would go, and with these patients would follow up to 24 months of follow-up. Looking at the demographics, as you can see that time from epilepsy diagnosis to venous surgery, a mean is about 23 years. Some of these patients had even failed surgery, at least a third had previously failed surgery, and 90% of these patients had failed more than 4 anti-epileptic medications. And 2/3 of patients had complete seizure stop or cessation during the stimulation with the VNS during the testing, as you can see in one example here. If you look at the responder rates at 3 as well as at 12 months, about 50% of patients had more than 50% reduction of seizures at 12 months follow-up. In addition to that, there is significant improvement in the overall quality of life. In addition to that, there is significant improvement in the overall quality of life. The main side effects was dysphonia that has been reported in about 20% of their cohorts, as you can see in this slide, based on the pooled E36 and E37 data. There's also some work in the UK group looking at the group of patients who had this new device implanted either as a result of dead battery with the old VNS or as a new implantation. And this is basically the cohorts of the patients who underwent that treatment. And they included 151 patients, either new inserters or as a result of change in the battery. And this is the demographics of the cohort, including the number of seizures prior to insertion. And if you look at the overall response, as you can see here, at least 20 to 30% of patients had more than 50% reduction of seizures, and about 30% had more than 80 to 99% reduction of seizures. 6% of patients had become completely seizure-free, and less than 10% had no effect of whatsoever after the implantation of the new VNS device. The Danish group had previously tested the concept of the transcutaneous vagus nerve stimulation, but no further work had been done since. There's some anecdotal data on the use of transcutaneous VNS, but had not been progressed since that time. What about other devices in managing patients with epilepsy? This is the RNS, which, as you know, is approved by the FDA for patients with difficult to control epilepsy. The RNS is designed to detect abnormal electricity in the brain and to deliver a small amount of electrical stimulation to suppress seizures before there are any seizure symptoms. They're obviously placed within the skull and underneath the skull by a neurosurgeon. And the RNS is obviously designed to continuously monitor brain electricity and obviously identifying the signature of a seizure onset and delivering the right stimulation before the seizure would progress. With that concept in mind, obviously it requires an accurate seizure localization. This is how the RNS look like and how it's implanted in the surgery. This is the work by Martha Morell that included 191 patients with 22 centers, 5-year long-term follow-up. Overall, if you look at the responder rate, was 74% for patients with hippocampal seizures, 30% for patients with neocortical seizures, and overall 47% for all patients. There was no serious device-related adverse events. And this is how the trial looked like, where patients randomized to either the device as compared to the sham group, similar to what we have seen with the design in the VNS previous treatment. If you compare both VNS as compared to the RNS, the infection rate tends to be a bit higher with the RNS, with 5% as compared to less than 1% with VNS. Hemorrhage, again, slightly higher in the RNS as compared to hemorrhage, but when it comes down to seizure reduction, responder rate, or seizure freedom, pretty much close in both treatment arms, meaning RNS or the VNS. Bob Fisher, back in 2010, had published the early report based on the Santer trials of the stimulation of bilateral anterior nucleus of this thalamus in patients with treatment-resistant epilepsy, suggesting this model of treatment can be effective in the group of patients with difficult-to-control epilepsy, with the median reduction of seizures close to about 56%, with few percentage had become completely seizure-free. There was obviously no serious device-related adverse events. 22% of patients had events related to stimulation, and there were 10% infection rates and about 1.3% asymptomatic intracranial hemorrhage. The FDA, however, did not approve the device because there were some concerns regarding suicidality, worsening anxiety and depression, and memory loss, but the DBS is approved by the EMA, as we had mentioned earlier. Very recently, there was some work in using the stimulation for the centromedian nuclei for patients with regional neocortical epilepsy, who are not surgical candidate, suggesting that model of treatment can be an option and quite be effective in patients with this neocortical epilepsy, with, again, stimulation of the centromedian nucleus of the in patient with regional neocortical epilepsy. Now, if we put the three devices alongside, VNS, DBS, and RNS, looking at various indications, indication for depression, using children versus adults, the loop type, side effects, as well as the regularity approvals, that we can appreciate the differences among the three models of neurostimulators in managing patients with various epilepsy syndrome. The work by Christopher DiGiorgio in LA had suggested the efficacy of trigeminal nerve stimulation in patients with drug-resistant epilepsy based on randomized controlled trials. And if you look here at the result of the trial, looking at 6 weeks, 12 weeks, and 18 weeks, you can see, for instance, at 12 weeks, patients were randomized to the treatment arm. 36% were responders, and 40% had become responder at 18 weeks as compared to 15% in the active control arm. Lastly, we have the work from the Chinese group suggesting the efficacy of low-frequency repetitive transcranial magnetic stimulation in patients with refractory partial epilepsy based on controlled clinical study, where they used the stimulation in the area of the epileptogenic zone focus. And as you can see in this slide, there was significant improvement in terms of higher responder rates in the treatment group as compared to the sham group. In addition to that, the time to new seizure had been much longer in the treatment group as compared to the placebo group. Again, that all suggesting the efficacy of repetitive transcranial magnetic stimulation in patients with difficult to control epilepsy. That, again, based on the Chinese group experience. I just want to leave you with final two thoughts: that neurostimulation therapies are a valid option and should be considered earlier than later in patients with difficult to control epilepsy who are, again, not surgical candidate, and the selection of which modality should be quite individualized based on several factors, including the underlying epilepsy syndrome, the underlying etiology, and obviously the patient's preference. With that, I end. And again, thank you very much for your attention. And I would like to thank the organizers one more time for their kind invitation to speak at this webinar. Thank you very much.
Thank you, Dr. Taoufik, for your nice presentation and elegant talk. And now, if you have any question, please use the Q&A option to write in your questions. So if we're gonna wait for some time until our colleagues write their questions, Dr. Ghaib asks the use of VNS in IGE. Is there any personal experience, and which type of seizures you would recommend it for?
As I mentioned in my presentation, we have some data of the use of VNS in patients with refractory idiopathic generalized epilepsy. There are also some data in the pediatric population of its efficacy in patients with symptomatic generalized epilepsy, including those with Lennox-Gastaut type, as well as other symptomatic generalized epilepsy. Based on my personal experience, I've used it in both subgroups with very good results, and there's some literature suggesting, as a matter of fact, better results in patients with generalized epilepsy as compared to the group of patients with focal epilepsy. And if you remember the data that I've shown in terms of meta-analysis review of all the studies that we have so far on VNS, and all the data have pointed out that probably we have a better results in patients with generalized epilepsies as compared to the group with focal epilepsy, although the FDA indication is very specific for patients with partial onset seizures, whereas in other countries, it's for all epilepsy or seizure types.
So all the available devices are covered for your patients by insurance, or do you have to go through a special way through that?
Unfortunately, it is covered by governmental sponsorship, meaning that for locals, I mean citizens of the country, they will be covered for that device with obviously specific indication, meaning that you have to fail at least 2 previous adequate trial of 2 anti-epileptic medications. But for non-citizens, the coverage would be dependent on your level of insurance coverage. For the high insurers, it might be covered with certain co-payment, but for the rest, it is not unfortunately covered.
Another question about treatment for progressive myoclonic epilepsy. What are your thoughts?
Well, are they referring to the use of neurostimulation in the group
Yes.
of PME or, okay. Well, that would be based on some anecdotal data suggesting that in case obviously medication is not working for that group of patients, there are some anecdotal reports of the utilization of VNS for that group. But again, that would be based on only small case series of patients who had failed various anti-epileptic medications.
And another question is, so for your patients who fail 2 anti-epileptic medication in a proper trial, do you try alternative modalities or you go for a third agent?
It has to be quite individualized. Yes, I mean, the data suggests that once you fail the second drug, your likelihood to respond to the third would become obviously less than 10%, but that has to be quite individualized. So you have to look at each case individually. So in some patients, I may go on a third trial of a new anti-epileptic medication, probably with a different mechanism of action. I may consider combining 2 drugs in some cases. And in other cases where I believe there is a good indication to proceed with either epilepsy surgery or with a neurostimulator, I will go for that right away. So this had to be looked at very carefully. But generally speaking, once your patient had failed the second drug, then you have to make a pause, review, and then you make a decision. Either you go for a third trial with a properly chosen drug or a combination of drugs, or you probably want to consider your patient for early epilepsy surgery or a neurostimulation option.
And another question we have about VNS. For patients who don't seem to respond to VNS, what is the maximum level of stimulation you would go for before quitting on it?
Well, if that question is referring to the duration, meaning how long you should wait on VNS before you can say that your patient is deemed not responsive to VNS, all the literature would suggest that the longer you wait, the more likely you find patient would respond to treatment. Meaning I wouldn't give up on VNS if your patient had less than 1 year of follow-up, because the literature is full of data suggesting that patient may respond after 1 year of VNS implantation. And that also mimic what we have seen in my own personal practice. So I would not call it not effective unless we have at least 1 year of work and follow-up. In terms of the parameters adjustment, obviously throughout that time you can adjust the setting to the best of your patient response and to the best of seizure control. And obviously every patient is different in how much they would or would not tolerate various settings.
And I'm also going to give a chance to Dennis to have a go at an answer to this question. Dennis, can you hear us? I think you need to unmute yourself. Okay, seems we have a connection issue. So with that, we would thank Dr. Taoufik for his elegant talk, and we proceed with the next half of our webinar with Dr. Fatma.
Thank you, Dr. Taoufik and Dr. Abdulaziz. Thank you, Dr. Taoufik, for the nice presentation, and always it's very informative presentation. And now we'll move to the second speaker, Dr. Thorpe Thompson. Dr. Thompson is the senior professor of neurology at the Department of Clinical Neuroscience, Karolinska Institute, and senior consultant at the Department of Neurology, Karolinska University Hospital, Stockholm, Sweden. His main research in epilepsy on pharmacotherapy, epidemiology, and pregnancy issue, and main contribution and research on SUDEP and pregnancy outcome in relation to maternal use of different anti-seizure medications. He has served on several commissions of the International League Against Epilepsy, and he's currently chairing the task force on women and epilepsy, women and pregnancy. He is FRCP Edinburgh honorary professor at the Honorary Medical University and a visiting professor, University College Dublin. He received in 2013 the American Epilepsy Society Research Recognition Award for his clinical science. Dr. Thompson will be presenting today on medication during pregnancy and postpartum period, and we'll first start the recorded presentation, and he will have the Q&A question live session after his presentation. Thank you.
Good evening, everyone. My talk today is about the use of anti-epileptic drugs during pregnancy and in the postpartum period. The ILAE Task Force on Women and Pregnancy recently conducted a survey among ILAE chapters across the globe, asking about the availability and use of guidelines for the management of epilepsy in pregnancy. You can see here in yellow the 77 chapters that responded to this survey. 56 of the responding chapters said that they did have guidelines. They also indicated the year when the guidelines they had were last updated, and you see the distribution in bar chart here. Importantly, a substantial part of the guidelines were updated before 2014, when the drug agencies came with their specific warnings on the use of valproate. And not so few were even as old as before the publication of the American Epilepsy Society and Academy of Neurology guidelines in 2009. In summary, the survey showed that most of the chapters that responded to the survey did have guidelines or recommendations. The sources of the guidelines were different, but as I showed you in the previous slide, a significant proportion of the guidelines in use were of old date and clearly before some of the more important new observations have been published. The recommendations, for instance, regarding folate supplementation varied considerably between the different chapters guidelines. And in at least 20% of the guidelines, there were no information on the possible risk to cognitive development. At least 20% did not provide any information regarding specific risks with individual specific anti-epileptic drugs. And just as many did not make any specific recommendations regarding choice of anti-epileptic drugs for the treatment of epilepsy during pregnancy. About 1/3 did not have any recommendations regarding the use of therapeutic drug monitoring during pregnancy, and almost 1/5 made no recommendations regarding breastfeeding. So there was apparent that there is a clear need of updated guidelines and recommendations, and in waiting for such evidence-based guidelines, the task force published expert opinions in epileptic disorders to assist epileptologists and neurologists in their management of epilepsy during pregnancy. So we're going to discuss this for the rest of my talk. And I think, first of all, it's important to agree on what the risks are, what the challenges, and what the goal is of the management of epilepsy during pregnancy. When it comes to risks, we need to be aware of that there are risks with uncontrolled seizures, both to the fetus and to the mother with epilepsy, but there are also, as you're all aware, teratogenic risks due to the use of anti-epileptic drugs. The challenge is to balance the risks caused by the anti-epileptic drugs against the risks associated with the poorly controlled epilepsy. And the overall goal of the management of epilepsy during pregnancy is to maintain seizure control, in particular of the major convulsive seizures, but do that with a minimized exposure to the fetus of drugs that are potentially teratogenic. So what are the fetal and maternal risks with seizures during pregnancy? I think it's reasonable to state that these risks are mainly associated with the major convulsive seizures, although there are a few exceptions. And with that I mean tonic-clonic seizures, be they focal or generalized from onset. And such seizures have been associated with fetal hypoxia and acidosis, with asphyxia, and if they come in the form of status epilepticus with fetal loss. And there's been one observation in a retrospective study indicating that frequent tonic-clonic seizures during pregnancy is associated with poorer cognitive outcome in the child, although that observation has not been confirmed in subsequent prospective studies. But we must not forget the maternal risks with uncontrolled seizures. And I'm just focusing here on the very severe consequences in terms of maternal mortality. And it's been observed that maternal mortality among women with epilepsy can be increased tenfold compared to among non-epilepsy women. This has been associated with SUDEP in most cases where the cause of death has been analyzed, and in a survey from the UK, also these maternal deaths were associated with suboptimal epilepsy care. So these risks need to be taken into consideration, and this is why we need to provide effective treatment during pregnancy, despite the risks associated with anti-epileptic drugs. And if we talk about these potential teratogenic effects, we need to be aware of that the type of adverse effects on the fetus depend on the time of exposure. I'm going to discuss 3 different types of outcomes in the fetus: major malformations, and as you all know, the sensitive period for that is restricted to the first trimester. When it comes to intrauterine growth restrictions or to adverse effects on the child's cognitive or behavioral development, it's likely that exposure throughout pregnancy is of relevance. Starting with growth restrictions, these are data from a Norwegian population-based nationwide study. As many of you may know, in the Nordic countries we have national population-based registries covering almost all pregnancies in the country that allow us to make population-based estimates of outcomes such as intrauterine growth. And in this Norwegian study, the researchers looked at microcephaly in yellow and the risk of small for gestational age in purple. This was analyzed for 7 different monotherapy exposures in the country during pregnancy. And as you see, topiramate comes out here with increased risks compared to all the other anti-epileptic drugs, both when it comes to small head circumference and small for gestational age. Similar data have been reported from a similar type of database from Denmark, confirming the adverse effects of topiramate on intrauterine growth. And this is a completely different type of study, but looking at the prevalence of small for gestational age along the x-axis. This is data from the North American Pregnancy Registry, that is a more selected cohort of pregnancies and exposed children. But as you see, also here, topiramate comes out with the highest prevalence of small for gestational age. But this is also seen with phenobarbital and zonisamide. But the consistent finding is with topiramate. Moving on now to major congenital malformations. The first message is that different anti-epileptic drugs differ in the pattern of malformations that they have been associated with. Although we all call them major congenital malformations, they differ in the severity. What we've done here is to look at monotherapy exposures with 7 different anti-epileptic drugs and the specific type of malformations they have been associated with. In blue, cardiac malformations; in yellow, neural tube defects; in green, clefts; and in purple, hypospadia. And what you see first is, for instance, if you look at barbiturates, preponderance for cardiac malformations. But if instead you look at valproate, you see increased prevalence across the board of malformation types, but in particular neural tube defects and hypospadia. And if you look to the far right, you see a signal with topiramate with an increased risk of clefts. So we need to keep that in mind, that when we talk about the overall risk of major malformations, they mean different things depending on the pattern of malformations for the individual drugs. This being said, I will focus on the overall rates of major congenital malformations in the subsequent slides. And what I've done here is to summarize data from 3 different prospective pregnancy registries, from Europe, the International Pregnancy Registry, from the North American Anti-Epileptic Drug and Pregnancy Registry, and from the UK and Ireland Pregnancy Registry. You see the prevalence of malformations along the y-axis, and along the x-axis you have 8 different anti-epileptic drugs in monotherapy. Across the 3 pregnancy registries, the pattern is fairly similar, with low prevalence of malformations with levetiracetam, lamotrigine, and oxcarbazepine. Whereas if you go to the far right, in all of the pregnancy registries, you have a high malformation rate in association with exposure to valproate, being in the order of 10% or so. So different anti-epileptic drugs carry a different risk, different level of risk of major congenital malformations. But it's not just a question of the drug, it's also the question of the dose. This graph shows data from the Europe Pregnancy Registry, and it demonstrates that there is a dose-event relationship, at least for these 4 anti-epileptic drugs. You see along the x-axis the malformation rate for valproate, phenobarbital, carbamazepine, and lamotrigine at different dose levels at the time of conception. And overall, you see that the higher the dose, the greater the risk of malformations. To take a few examples, with the low dose of valproate up to 650 milligrams per day, the malformation rate was similar to that seen with the high dose of carbamazepine, whereas a low dose of carbamazepine was associated with a similar malformation rate as a high dose of lamotrigine. So the message here is that it's not just the type of malformation, type of anti-epileptic drug, but it's also the dose that is used that you need to consider when you estimate the risk for your specific individual patient. And this can be done in different ways. You will find at least 30 different direct comparisons in the publication that is referenced here. This is one way of doing it. What we did here, again, these are data from Europe, was to set the malformation rate with the treatment associated with the lowest risk, that was lamotrigine up to 325 milligrams per day as the reference, and then we calculate and demonstrate here the odds ratio for malformations compared to with that lamotrigine dose at different dose levels of different anti-epileptic drugs in monotherapy. And you can see that with the phenobarbital at the low dose, the risk was similar to that of low dose of lamotrigine, and that was also the case with levetiracetam and oxcarbazepine at any dose. Whereas if you go to the right, you will see that higher doses of phenobarbital are associated with a greater risk, and to the far right, you see that any dose of valproate is associated with a greater risk. So the drug and the dose at the time of conception. What have we learned over the years? We've modified our drug selections for the treatment of epilepsy during pregnancy, and this is demonstrated in this figure, based again on data from the Europe Pregnancy Registry. What you see is the use of different anti-epileptic drugs in monotherapy during pregnancy in this registry over a 14-year period from 2000 to 2013. And you see on the top of the graph the increased use of lamotrigine in brown, and in dark blue the increasing use of levetiracetam, whereas the use of carbamazepine in yellow and in light blue of valproate has decreased over the same time period. Here we superimpose the rate of malformations over the same time period, and you see that in parallel with these changes in medication use, the malformation rate has been decreasing. And if we compare 3 different time periods over these 14 years, you see here in blue the rate of malformations in monotherapy, and in orange in polytherapy. And you see in monotherapy as well as in polytherapy, if you compare these time periods, at least a 25% decline in the rate of malformations. And our statistical analysis clearly indicates that this decline in malformation rates is associated is related to the changes in medication preferences. So it indicates that our change in drug selection during pregnancy does make a significant difference when it comes to outcomes. This is data from the Australian Pregnancy Registry, looking specifically at changing medication before conception with valproate. There are 3 groups of pregnancies. The first was pregnancies where valproate was kept unchanged, not changed before pregnancy. Second was pregnancies where valproate dose was reduced before pregnancy. And the third, pregnancies where valproate treatment was terminated before conception. And you see that the rate of malformation declined with the decline in dose of valproate, and with, in particular, when valproate was withdrawn before pregnancy. There was also, however, a trend for seizures to be more common during pregnancy among women whose valproate medication had been reduced or withdrawn before conception. I'm moving on now from malformations to cognitive outcomes. And this slide summarizes the data from the 2 most important studies in that respect. And the upper part of the slide shows data from the NEED study, which included and enrolled women in early pregnancy if they were on treatment with monotherapy with lamotrigine, carbamazepine, phenytoin, or valproate. And the children were assessed at the age of 6 for their IQ. And the finding was that the children that had been exposed to a high dose of valproate, defined as above 1,000 milligrams per day, had a lower IQ than children exposed to any of the other medications. The lower part of this graph shows a study which was published some years later, which to about 50% included the same exposed children as in the NEED study, but it also added controls, children of healthy mothers and children of mothers with epilepsy that were not treated with anti-epileptic drugs during pregnancy. Again, the children exposed to a high dose of valproate, here defined as above 800 milligrams per day, had a lower IQ than the other exposure groups or the controls. However, unfortunately, there were no safe dose levels of valproate identified in these studies. It was observed that verbal abilities were impaired and educational interventions increased also among children that had been exposed to lower doses of valproate than 800 milligrams per day. So no really safe valproate levels. What do we know of exposure to other newer generation anti-epileptic drugs in addition to lamotrigine and cognitive outcomes? This is a follow-up study of the UK Island Pregnancy Registry and selected sample of that. Again, you see that with valproate, the outcome was worse. But this is what we have in terms of outcomes with exposure to gabapentin, to pyramate or levetiracetam. No bad signals here, but the important thing is that the number of exposed is very limited, and we do need additional data on these outcomes with these newer generation anti-epileptic drugs before we can draw any really firm conclusions. The Danish researchers, as I mentioned, had access to the population-based nationwide register data. And they utilized these data to look at outcomes such as autism and autism spectrum disorders among children that had been exposed in utero to different anti-epileptic drugs. And they found that the risk of autism spectrum disorder was increased threefold among those exposed to valproate compared to not being exposed to valproate. And for childhood autism, the increase was almost fivefold. They did not see a similar pattern for any of the other anti-epileptic drugs that they analyzed. This is a very recent publication, as you can see, based on similar types of register data in the national population-based registers, but this time from Sweden. It included more than 3,000 children that had been exposed to any anti-epileptic drug during pregnancy, of which almost 700 were valproate, almost 1,000 lamotrigine, and 1,400 carbamazepine. And the hazard ratio for autism spectrum disorder with exposure to valproate was 2.3. For ADHD, the hazard ratio was also significantly increased with exposure to valproate, 1.7, whereas no similar associations were noted for exposure to carbamazepine and lamotrigine. So again, confirming in an independent register-based study the findings of the Danish study with an increased risk of autism spectrum disorders among children that had been exposed in utero to valproate, but not to other anti-seizure medications. Another very recent study, also register-based, comes from France, including large numbers of exposed children. As you can see, if you break it down to monotherapy and combination therapy exposures for the different anti-epileptic drugs, you see that almost 1,000 valproate exposures in monotherapy were included. The endpoint here was a sort of a composite, which they called neurodevelopmental disorders, and you see the ICD code corresponding to that. So that's a sum of some subcategories that were found in the registry. The findings were as follows. For valproate was associated with an increased risk of this composite neurodevelopmental disorders with a hazard ratio of 3.7 overall. If the analysis was limited to children of mothers without mental illness, the hazard ratio was 5. The effect of the exposure to valproate on the neurodevelopmental disorders was dose dependent and was significant mainly at doses above 1,100 milligrams per day. And interestingly, the effects on neurodevelopmental disorders was significant only when valproate exposure involved the second and the third trimester. This just shows you a breakdown of the different types of neurodevelopmental disorders that were assessed for valproate exposed children and those exposed to the other drugs. And when it comes to the non-valproate drugs, there was no consistent association between exposure during pregnancy and neurodevelopmental disorders among children or mothers with no known mental illness. The French study had a mean follow-up of 3.6 years. The NEED study and the other studies I've mentioned in general analyzed the children at the age of around 6 years. An important question is to what extent data at that time predict the performance later in life. And this is analyzed in another report from the Danish research group, again utilizing national general health data and performance data. What they did here was to look at the routine tests later in school of mathematics and language, and linked that to exposure to anti-epileptic drugs in fetal life. And they found that those exposed to valproate in utero performed worse later in school in language and in mathematics compared to all other exposures or no exposure, confirming that the data we see in early age are probably indicating a poor performance also later in life. So if we summarize what we could do based on what we know, the important message is that if you want to make a real difference, your chance to do that is before pregnancy, before conception. I think one need to take into account future pregnancies already at the stage when you consider to start treatment of epilepsy in a young woman. In those on treatment, the indication of the treatment and the choice of treatment should be reassessed at regular levels before conception. Whenever possible, valproate should be avoided, and regardless of which drug that is used. In planning pregnancies, one should try to establish the lowest effective dose and to document the effective concentration of that drug before conception. It's also important to consider folate supplementation. The question is what dose? When we asked about this in our global survey to the ILAE chapters, it turned out that the recommendations varied from no recommendation and from low dose up to 4 milligrams per day. So what do we know about folate supplementation? We know that 0.4 milligrams per day is recommended to all women during pregnancy, and there's no reason to accept women with epilepsy from such a recommendation. Unfortunately, we do not have any randomized studies in women with epilepsy looking at the effect of folate on pregnancy outcomes. When it comes to malformations, the pregnancy registries that I've quoted before do not provide any support for a reduced risk of major malformations among children whose mothers took folate periconceptionally compared to those that did not. From the other observational studies, such as the NEED study, we do not have support that folate reduces the adverse effects on cognitive development that are shown for valproate. However, observational studies, including the NEED study, suggest a positive effect of use of folate on cognitive development in children exposed to other anti-epileptic drugs than valproate. But the optimal dose is unclear, unfortunately, so it's difficult to make firm recommendations here. So far, we've discussed the teratogenic potential, and as I mentioned initially, this has to be balanced against efficacy. And efficacy is also related to pharmacokinetics, and we know that the drug levels of several of the anti-epileptic drugs are altered by pregnancy. And I made a very simplified table here, indicating to the left anti-epileptic drugs where we have major declines in serum concentrations during pregnancy. The important thing is that these are averages, and individual pregnancies may see very different changes in serum concentrations. So it's very difficult to predict, although for some anti-epileptic drugs, such as carbamazepine, changes in general are really minor during pregnancy. And then we have a range of anti-epileptic drugs, the newer ones, for which we really don't know what pregnancy does with the serum levels. The question is, do these levels matter? Do they have any consequences for seizure control? I think we have data that clearly indicate that this is the case, and they mainly come from prospective studies from the US by Paige Pennell's group, showing that there is an increased risk in seizures if serum concentrations fall by more than 35% during pregnancy compared to the optimal pre-pregnancy concentration. The question is if therapeutic drug monitoring can help us. This is a meta-analysis, and to the left you see case series where therapeutic drug monitoring was used to optimize, or with the aim to optimize treatment during pregnancy. To the right you see case series where TDM was not used during pregnancy. And what you see along the y-axis is the rate of seizure deterioration. And this meta-analysis clearly indicates that the risk of seizure deterioration was lower when TDM was used. So what shall we monitor and how? It makes sense to monitor in particular those drugs for which we know that we have major changes in serum concentrations, such as lamotrigine, levetiracetam, oxcarbazepine, and zonisamide. And I would make a case to monitor also the anti-epileptic drugs where we don't have any solid information on the effects of pregnancy, if we have the methods available. When it really makes a difference if we have a pre-pregnancy optimal serum concentration to use as baseline. That is really very helpful. And after that, we should take the first sample as soon as pregnancy is known, and thereafter the frequency by which we sample will vary depending on many things, like the type of anti-epileptic drug, like the prior sensitivity in that individual patient to changes in serum concentrations, So it would vary from, say, once per trimester up to more than once monthly. If the dose has been changed, increased in most cases during pregnancy, it's recommended to monitor the new serum concentration at the latest a week after delivery. Total concentrations in most cases, but if we have highly protein-bound drugs such as phenytoin, valproate, and perampanel, pre-levels are recommended if that is possible to measure by IR. How do we use it? If there's an increase in seizures, we increase the dose guided by TDM. If the patient is seizure-free, but we see significant decline in drug levels from baseline, we should consider the dose adjustment to restore the baseline levels, provided that baseline levels are the lowest effective level before pregnancy. If we don't have any pre-pregnancy baseline level, it's reasonable to consider the first pregnancy level as the baseline. And if the dose has been increased during pregnancy, consider reduction within a few days after delivery. What about changes in medication during pregnancy? I remind you of the sensitive periods here. What do we know? We have data from the Europe Pregnancy Registry looking at seizure control after withdrawal of valproate during pregnancy, or after switching from valproate to another anti-epileptic drug during pregnancy. And it's clear that those that had the valproate medication withdrawn or switched during pregnancy had a significantly higher risk of major convulsive seizures during pregnancy. So such switches are associated with increased risk of seizures. What do we know about Territoric Outcomes? Not much. We have data from the Kerala Pregnancy Registry, where medications were reduced or withdrawn in a small percentage of pregnancies during pregnancy. And there was no difference in the frequency of major malformations or in developmental outcomes in the groups that had their medication switched or withdrawn during pregnancy, unfortunately. So if we summarize what we know about withdrawals and switches during pregnancy, they are associated with the risk of major convulsive seizures. If we switch, such a procedure is associated with exposure to polytherapy during the transition period. It's associated with unknown efficacy in the woman in question of the new drug, and with unknown tolerability of the new drug in the woman that we are switching medication for. It's unlikely to reduce the risk of malformations due to the sensitive periods, as I mentioned. And we don't know if it's associated with improved neurodevelopmental outcomes. It might be, but we don't know. So during pregnancy, we should avoid seizure precipitants. We should monitor treatment to maintain seizure control, and I discussed that in more detail a few minutes ago. I think it's fair and reasonable to be cautious with switches and withdrawals of medication when pregnancy is already established. We should consider offering prenatal diagnostics, and we should prepare the woman for delivery. What about after pregnancy? I think the most important message here is that we can encourage breastfeeding. The table you see here is summarizing data on serum concentration, breast milk concentrations among children exposed to different anti-epileptic drugs during breastfeeding. In most of the cases, if we look to the right of the table, serum concentrations in the breastfed infants are really very low compared to maternal concentrations, with a few exceptions. With lamotrigine, the infant serum concentration can be in the order of around 25% of the maternal serum concentration, and similar and slightly higher ratios with sunisamide. But the reassuring thing is the observation from the NEED study, which found that IQ at 3 or 6 years among the children that had been breastfed versus not breastfed infants of mothers taking valproate, lamotrigine, carbamazepine, or phenytoin did not show any negative effects of breastfeeding. So after pregnancy, I think we can encourage breastfeeding regardless of the treatment with anti-epileptic drugs. And as I mentioned before, if the dose of the anti-epileptic drug has been increased during pregnancy, we should readjust the dose very early on after delivery. And with that, I thank you very much for your attention, and I'm happy to take questions.
Thank you, Dr. Thompson, for this very nice and very informative and clear presentation. While we're waiting for a question from the audience, so I might start with the first question. So as you clearly mentioned from the data from the NEEDS trial and other trials with the side effects of valproate, so the trend now, most of the patients have been switched to the other alternative medications. And one of the common scenarios that we see in the clinics, patients who are on primary generalized epilepsy are on lamotrigine or levetiracetam, and sometimes in combination. And yet still they are not controlled. So what's your suggestion regarding to this? Is it recommended to switch some of them to valproate, given the data that you have mentioned that the lower doses, usually it's almost equivalent to the other medications?
I would say that I would still, as much as possible, try to avoid valproate, because it's clear that we cannot say that there are safe doses, even though the IQ on average for the lower doses was not different from some of the other exposures. There was still, as I mentioned, indications of poorer cognitive outcomes in those exposed to valproate. We also have, at least in Europe, very, very strict recommendations from our drug agencies requiring us to, well, actually they're saying that valproate is contraindicated in pregnancy. And we are obliged to also provide detailed written information regarding the risk with valproate to all women that are of childbearing potential if they are on valproate. And these need to be signed once a year. So the regulations are extremely strict. And I would say that as much as possible, it makes sense to avoid valproate. If you're in a situation where valproate cannot be avoided for a woman that is of childbearing potential, and I'm not discussing during pregnancy now, I'm discussing in preparation for pregnancy, I would say that it's probably, and I didn't show that, but it's probably better if you can keep the valproate dose as low as possible by adding another medication, like lamotrigine or any other medication. A combination of valproate plus another medication is probably safer than having a higher dose of valproate in monotherapy.
Okay, thank you. Yeah, because there are patients who are on maximum doses of both levetiracetam plus lamotrigine, and still the EEG is still showing lots of epileptiform discharges, and clinically they are having a seizure. So thank you for that. So there is one question from the audience that the question is that the withdrawal of anti-seizure medication, they are doing it just before the pregnancy. So the question is, what's the best moment during pregnancy to avoid a newborn malformation and cognitive consequences?
What's the best moment? For malformations, the sensitive period is the first trimester, and probably the first 7 or 8 weeks or so. But for cognitive outcomes, it's likely that the entire pregnancy is the sensitive period. So actually, if you want to make a difference, you would need to act before conception. And I usually say that if you want to try a withdrawal or try a switch to another medication, you should initiate that at least a year before a planned pregnancy, if that's possible. Because first of all, you need to make the change in a safe way, and then you need sufficient time to assess whether the new treatment, be it no treatment or be it another anti-epileptic drug, actually works. So I would initiate that about a year before conception. And how can we do that? I think our task is to, if we are taking care of young women with epilepsy that are under medication, this is the thing to bring up at every consultation once a year. Are you planning a pregnancy? Is there anything we can do to reduce the risks?
Okay, and the other question, the participant is asking, I have seen 3 previously healthy women who have developed focal epilepsy during pregnancy with normal MRI and focal interictal discharges on EEG. I could not find an article about the onset of epilepsy during pregnancy. Any personal experience?
Only a few odd cases, but I know there are some articles about that. I think Professor Sanjeev Thomas from Kerala has published a paper on that. You can try to make a literature search on that. So I mean, that happens. And of course it happens, because pregnancy is not protecting you from onset of epilepsy. It's like any other 9-month period in life. So it happens, of course.
Thank you. So there is a question: if a mother controlled on lamotrigine 250 milligram BID, and after delivery by 2 weeks, the infant developed rash, what can we do? Ask the mother to stop breastfeeding?
How long after delivery was it?
2 weeks.
2 weeks.
2 weeks.
Yeah. That's a tough question, because on the one hand, you would expect that the child, when it was in utero, was exposed to lamotrigine for the whole gestational period. So it's a bit strange with an idiosyncratic effect coming like 2 weeks and 9 months after the first exposure, like this would be. On the other hand, I'm not sure that the reaction of the immune system is the same in utero as it is after birth. So it might be an idiosyncratic reaction. I would due to lamotrigine, I would first of all consider if there are any other possible triggers to a rash than the lamotrigine, and if there are none, I would probably advise against continued breastfeeding, if that was an answer.
Thank you. So another question: a pregnant woman well controlled on valproate 1 gram a day in the 2nd month of her pregnancy, what to advise?
then I would have to give her the tough information about what the risks are. And I would say second month, it's I cannot see how I could withdraw that medication safely in a way that would protect her or protect the fetus from the adverse effects. So I would not withdraw the medication. I would clearly inform the woman of the risks associated with valproate exposure, which then are substantial, in particular at that dose level. So I would not withdraw it. I would not change to another medication. Would it make sense to consider a reduction in the dose? That depends on her pre-pregnancy history. If it's clearly shown that she needed this dose of valproate to control major convulsive seizures before pregnancy, I would probably not even consider a dose reduction. But I mean, she is entitled to get the full information of what the risks are. That's a very tough situation.
Thank you. And another question, I think you have answered it in your presentation. So what is the lowest safe dosage of valproate permitted in pregnancy when we are obliged to use it or continue with it?
There's no such, I mean, there's no safe dose, if that's the question. It's a gradual increase in the risk with the dose. The risk is lower with below 800 milligrams. It's probably even lower below 600 milligrams, etc. So it's a gradual thing. We cannot define a completely safe dose.
Okay, another question. So what is the drug of choice, in your opinion, in pregnancy for primary idiopathic generalized epilepsy after levetiracetam?
After levetiracetam. Well, let's compare levetiracetam and lamotrigine because we have, when it comes to major malformations, they are probably of the same level of safety. But when it comes to cognitive outcomes, neurodevelopmental outcomes, we have much more data on lamotrigine than we have on levetiracetam. So we know more about the safety profile of lamotrigine than we know of levetiracetam. So that is to the advantage of lamotrigine. But I would say that when it comes to malformations, they are both comparatively safe and probably the safest alternatives we have. If that's the answer, an answer.
Okay.
What would be an additional alternative? The only one I can think of is sunisamide, but with sunisamide we don't have any reasonable data on cognitive outcomes, and the data we have on malformations is very limited. I would say if we combine the data from the Europe and the North American registry, it's in the order of 200 prospective cases, but with very few malformations. So there's no bad signal there, but it's very limited information, and as far as I know, no information on cognitive outcomes.
Okay, thank you. So there is another question. Do you recommend increasing the doses of anti-seizure medication if women are having focal awareness seizure exclusively, considering the relation between the side effect and the doses?
I would. This is something you would have to individualize. It depends on how affected she is. If those seizures make a major difference to her quality of life, maybe. But if we just consider the fetus and their focal aware seizures, and the focal aware seizures are not in her pre-pregnancy history indicating an increased risk of focal to bilateral tonic-clonic seizures, I would be less active in increasing the dose than I would be if she had major convulsive seizures.
So there is a question, this is actually my question. In our region, I think they are not, all the centers have all the drug levels. Like, it's very common to have for phenytoin, for carbamazepine, phenobarb, but the other newer anti-epileptic medications are not there. And since we are very commonly using lamotrigine, levetiracetam, and other newer anti-epileptic medications, so what's your recommendation for those who already have pharmacodynamic changes during pregnancy? So how we should handle the patients? Do we wait until they get seizure, or there is a predicted time where you can increase the doses according to the pregnancy weeks?
And that's also a tough situation. And I think the fact that you have these major changes in serum concentrations during pregnancy of lamotrigine and levetiracetam, drawbacks of these medications when you cannot monitor the drug levels. But if that's the situation you're in, first of all, again, go back to this individual patient's pre-pregnancy history. How sensitive was this woman to changes in doses? Do you have good data to indicate that she is in fact entering pregnancy on the lowest effective dose, or whether it's lamotrigine or levetiracetam? If that's the case, I would rather be proactive than reactive. So I would not wait for breakthrough major convulsive seizures. A compromise which is, I would say, clearly in most cases compensating less than full compensation would be to say by week 20 or so, increase the dose by about 50%. That would be less than needed for most, but you would avoid over-treating any woman if you do that. So after week, the decline takes place already during the second trimester. But increasing the dose at week 20 is a reasonable compromise, even if she's not having seizures. I mean, this is to prevent major convulsive seizures. And in most of the cases, it would not restore her pre-pregnancy serum concentrations. But we don't want to overcompensate any woman.
Okay, then. Thank you very much. I think that was the last question, and I would like to thank you, Dr. Thompson, for this excellent presentation, and would like to thank also Dr. Taoufik Alsaadi for his presentation. And that concludes our webinar for today. And hopefully we see you on the next month webinar. And by then, stay safe all. Thank you and good night.
Thank you for having me.
Good night. Thank you.
Good night.